Ladies and gentlemen, dear colleagues, thank you for having me today. It's a great pleasure and honor. I have many topics to talk about today. And first of all, I would like to tell you that I do not have any conflict of interest to declare about this lecture. So when we talk about the diabetic foot, we talk about a syndrome with a very high mortality rate and with a very high amputation rate. This is the reason why today we talk about multidisciplinary approach, we talk about teams, and in particular, the Italian Diabetic Foot Study Group identified at least 4 teams in order to manage the disease. This complication, of course, the medical team, the foot surgical team, the vascular and endovascular team, and of course the prevention and rehabilitation team. Talking about the diabetic foot syndrome, we talk usually about 3 different clinical features, 3 different clinical aspects: the neuropathic fit, the Charcot fit in the acute phase or in the chronic phase, and of course the ischemic or neuroischemic foot. And if you remember, in 2007, the Eurodialysis study stated that more or less we have 50% of patients with neuropathic fit and 50% of patients with ischemic or neuroischemic fit. But actually, in my personal experience, today things are a little bit different. Today, in my personal experience, in my daily activity, we have more or less 30% of patients with pure neuropathic foot and 70% of patients with ischemic or neuroischemic foot. And talking about neuropathic foot, the treatment is almost easy. If you read at least this slide, we talk about debridement, toilet, surgical toilet, good wound care, and of course, the main important treatment is the offloading. They are simple tenets, but in some cases, we have a lot of difficulties in order to achieve the wound healing. Why debridement is important? Because it transforms a chronic wound in an acute wound. Chronic wound with a very low grade of wound healing, and an acute wound with high probability of wound healing. Good wound care, it means to use everything we have in order to speed up the wound healing process. Sometimes it's the use of correct dressings, sometimes it's the use of surgery, depends on the lesion, depends on the patient. And of course, the most important part of the treatment is very well summarized in this historical paper published by good friends of us, David Armstrong, Laurie Lavery, Andrew Bolton, etc. It's not important what you put on, but it's really important what you take off. The hyperpressure, the debridement, etc. Today we know that the first choice when we have an ulceration in the plantar aspect of the foot, according to the international guidelines, is the use of knee-high devices. As a first choice, total contact cast or removable or non-removable knee-high devices. And actually, Italy gave a lot of information about the use of this kind of devices. These are some of the papers, randomized clinical trials published by some groups, from some Italian groups. There is also a paper or a couple of papers published by our group. And today we know exactly what we have to do when we have an ulceration in the plantar aspect of the foot. And when this kind of knee-eye devices are contraindicated or not tolerated by our patients, we can use other kinds of post-operative or offloading devices, like the devices that you can see in this slide. Unfortunately, even when we are good in our treatment, when we use all these three tenets, sometimes we have a non-healing neuropathic ulcer. And so we have to think about other strategies. For example, when we have an ulceration with recurrences, and when after using the correct offloading devices, we still have recurrences and new ulceration, sometimes we have to think about surgery. Surgical offloading is a procedure for diabetic foot ulcers, in particular when we have, for example, deformities, when we have severe deformities and recurrences, despite the use, for example, of secondary prevention shoes, secondary prevention insoles, or inserts. When we have deformities, we have to think about surgery. We have to think about foot reconstruction in order to give the patient a plantigrade foot at low risk of ulcerations. This is a typical example: ulceration, non-healing ulceration in the plantar aspect of the foot, with prop to bone test positive, with tendon or bone exposure. In this case, this patient had an osteomyelitis. We carried out a surgical debridement of the bone with the osteomyelitis. We use some beans with antibiotics. You can see here, we remove the osteomyelitis. We try to avoid the minor amputation with a first ray amputation. We allow the patient to walk during the treatment with an offloading device, knee-high offloading device. You can see after a few days after the surgical procedure, and you can see that after a few weeks we have the complete wound healing. And of course, we have to keep in mind that secondary prevention shoes in these patients and insoles are mandatory. Another option is the metatarsal head resection, very easy to carry out, very easy to do. Achilles tendon lengthening is another procedure very easy to carry out in order to reduce the peak plantar pressure in the forefoot. And there is another reason why sometimes we have a non-healing ulceration. For example, the presence of peripheral arterial disease. Today we know that peripheral arterial disease and infection tripled the likelihood of non-healing. In some cases, like in this picture, you have an ulceration in the plantar aspect of the foot. It looks like a neuropathic plantar wound, but actually, if you carry out some non-invasive test, you can see that we have an ankle pressure very low, a TCPO2 pressure 12 millimeters of mercury, and an ankle brachial index very low, and they confirmed the diagnosis of neuroischemic foot. So today we know that when we have an ulceration with ischemia, with chronic limb-threatening ischemia, and non-healing lesion with chronic limb-threatening ischemia, the revascularization is the key point, the key corner of the treatment. Revascularization is mandatory, and of course we have to think about the offloading, dressings, the use of adjunctive therapy, but without forgetting that the revascularization is the key corner in the treatment. Another problem in non-healing ulcers is the presence of infection. In some cases, we have a non-healing ulcers just because we have an infection or deep infection. Diabetic foot infections account for about 20% of hospitalization in people with diabetes and account for at least 50% of all non-traumatic lower limb amputations. Osteomyelitis is present in almost 20% of cases of foot infection in persons with diabetes, and as many as 25% of all diabetics are expected to develop severe foot problems at some point in their lifetime. So when we have an ulceration, a non-healing ulceration, always think about arteriopathy or think about infection or think about that the offloading you have chosen is not the correct offloading. Osteomyelitis in many cases is the cause. In those patients presenting with infected diabetic foot ulceration, underlying osteomyelitis is present in as many as 65% of the cases. So in conclusion, diabetic foot is a syndrome, and the multidisciplinary approach is the only way we have for reducing the amputation rate among persons with diabetes. Offloading, conservative or surgical offloading, debridement, and wound bed preparation are the cornerstones of the treatment. Incorrect offloading, ischemia, and infection are all factors influencing the outcomes in patients with diabetic foot ulcers. Thank you for your kind attention, and thank you for inviting me.